It's really the last talk today, and it's going to be very sort of general overview talk of neurosurgical emergencies. So what are our goals when somebody has a neurosurgical emergency, or really the goal of neurosurgery in general is to preserve functional life. We're not looking to keep people alive that are going to be vegetative. We're not looking to keep people alive that wouldn't want to be alive in a certain condition. And everybody has their own wishes on how they want to live their life if they were injured. But we basically want to preserve a functional life and keep it as functional for as long as possible. Avoid vegetative occurrence in a severely compromised state. We want to minimize further CNS injury, and that's really important. Somebody comes in with a neurosurgical injury, or I'm using the term injury. It doesn't have to be a traumatic injury, but anything that's injurious to the brain. We can't fix that problem. I mean, that problem already happened. The brain's already damaged. What we want to do is limit secondary injuries to the brain that are a consequence of the primary injury. And the underlying goal, in the majority of cases, the final common denominator is to maximize oxygenation by maximizing cerebral blood flow and oxygen retention within the blood. And that goes for, if you got a bullet to the brain and there's mass effect from damaged brain you need to take out. If you have a blood clot somewhere in the brain, it doesn't matter where. There are other reasons to operate for, let's say, a bullet to the head or a knife to the head, which might be potential bleeding or infection or to avoid infection. But the life-saving and life-preserving issues that generally arise from anything having to do with the brain are, how does this problem impact cerebral blood flow and subsequent delivery of oxygen to tissue that is continuing to, that is currently alive. This is a really small, I couldn't get this font together, I really apologize. But what are some typical neurosurgical emergencies? I put in stuff here that you normally wouldn't think of, but because of our practice, you should. Groin hematoma. People can die from a groin hematoma if they have excess bleeding or bleeding out. People obviously can lose limbs from distal limb ischemia if a femoral artery throws blood clots or is occluded. And going along with that is retroperitoneal hematomas. Very often we can we try to puncture the femoral artery below the inguinal ligament so that it's not in an area that's contiguous with the retroperitoneal region. But sometimes we have to puncture above that, and we can get bleeding from that artery continuously into the retroperitoneal space. That can hold a tremendous amount of blood that you can't detect on a neurologic exam. So people that have hypotension, complain of back pain, have drops in their hematocrit that can't be explained. After even a simple arteriogram, you need to suspect a retroperitoneal hematoma. Other emergencies are stroke-related. These can be spontaneous or iatrogenic. Carotid disease, dissection, we talked about earlier, the injury to the wall of the blood vessel. Atrial fibrillation causing stroke as blood clots get thrown to the head. Atherosclerotic disease, either intracranially or extracranially. Damage from surgery. All of those things can cause narrowing of blood vessels and development of blood clots and decreased blood flow to the brain. Other things you don't think of as a neurosurgical emergency, but airway compromise. I know you do a fair amount of cervical discs here. Anybody with a cervical disc can have airway compromise afterwards, either from a hematoma in the neck, swelling of the soft tissues around the trachea, and those people can expire quite quickly in the postoperative period. Vocal cord damage, vocal cord swelling from prolonged intubations or traumatic intubation can cause airway loss. And so those are people that we really want to be very cognizant of. Generally always want to have a surgical airway kit accessible somewhere nearby the ICU or the OR or the recovery rooms that CRITE can be performed quickly. Somebody has a hematoma in the neck, not something you have to wait to go to the OR for. If they have an airway problem and a deviated trachea, and they can't be intubated because of the deviated trachea. That's something that you would just open the incision, right there at the bedside, let the blood clot out, intubate them, and then take them back to the OR, close the wound up, irrigate it. Nothing terrible is going to happen from that. Other airway problems. I talked about the cord injury and the swelling. How about extremity weakness? Okay, I'll just move to the next slide. Extremity weakness, that can be both from brain injury, it can be from a new disc herniation, it can be from damage to the spinal cord or nerve roots during surgery. Those are things that we want to be aware of, both post-operatively, but those are things that patients come into the ER with. There are really very few non-traumatic spine emergencies except for new onset weakness, new onset bowel and bladder dysfunction, whether it's a cauda equina syndrome or a nerve root syndrome. We generally want to treat people, although the evidence is scant about whether or not operating on people early or late is necessary in people that don't have a complete deficit. We generally do want to operate on people, except for certain circumstances, that have new onset deficits as early as possible. It goes back to the original talk we did today, that the earlier you can operate on somebody and the better condition they're in before surgery, the greater the likelihood is that they're going to have a meaningful recovery afterwards. I talked about bowel and bladder problems. People that have sudden loss of bladder, bowel control is much less common, but a bladder control of incontinence from a disc herniation, that's generally considered a neurosurgical emergency. Needs to be treated as soon as possible. And that can be from a disc herniation, but you can also have those problems from people that have atherosclerotic disease and spinal cord ischemia, AVMs in the spinal cord, tumors. So there's lots of things that need to be worked up. Generally, those types of findings are worked up with an MRI scan acutely to differentiate between the different problems and find out whether or not they're surgical or not surgical, or if they're emergent or non-emergent. CNS infections, that is a neurosurgical emergency, whether it's to be treated meningitis, that's post-surgical or post-trauma that needs to be treated with antibiotics. Cerebral abscesses that can rupture into the ventricles and take people's lives are generally neurosurgical emergencies. Sometimes they're picked up, sometimes you're focusing on the wrong things and you don't get that evaluated quickly enough. Now that people are generally coming with a neurologic deficit to an ER, get scanned pretty quickly as an initial part of the initial evaluation. Those things usually get picked up. Sometimes they get confused with tumors and other problems, but as long as somebody's gotten the scan and somebody's reading it and knows what they're reading, you should be able to at least put that in the differential and decide whether or not they need emergent surgery for evacuation or just antibiotic therapy. Increase intracranial pressure, that's the thing we think of the most, and we've talked about that kind of ad nauseum today. It happened for multiple reasons. Anything that you add to the brain, the contents of the skull, in excess to the brain that's already there, the blood that's already there, flowing through it, and the spinal fluid that's already there, can increase intracranial pressure. And the more quickly you add something, the larger it is, the more quickly it becomes a problem. The reason people tolerate tumors for so long, many tumors, is because they grow so slowly that the brain can get used to it and it can accommodate for a new mass in the head. But the reason that you can't tolerate a fresh blood clot in the head is it comes on very quickly and the brain just can't accommodate to it. Once again, generally those things are picked up with imaging, but they do need to be addressed quickly again not because there's blood in the head, not because there's a blood clot in the head, but it's because it's putting pressure on the brain, it's reducing blood flow to part of the brain, and that brain can die if you don't restore the normal architecture. So how do we treat the emergencies? Well, there's blood clot, we may or may not evacuate it. Every time somebody has a blood clot in their head or their brain, it doesn't mean the blood clot has to come out. You take the blood clot out if you think it's going to make somebody better. You take the blood clot out if they're worsening. You take the blood clot out if those things are true and it's accessible without causing further damage to them. But there are some people we leave the blood clot in because we say, it's caused them a problem, it's causing a deficit, but if I take it out, I'm not going to make them any better right now, and I may make them worse by taking it out. It's going to let it go away on its own. So not every blood clot in the head is a surgical emergency or is even surgical at all. Does it need to be evaluated? Yes, you need to make a determination. And again, neurological examination is very important in the people that don't get surgery for that, because we want to see if they're worsening. If they are worsening, then have they become a surgical candidate? Obviously, the A, B's, and C's, everybody knows about. Intubate or obtain a surgical airway, probably the most important thing in somebody who is not responsive or cannot follow commands with a neurosurgical emergency. And again, it goes back to making sure the brain stays oxygenated. Talked about emergently removing disc or decompressing the spinal cord, and when Rich gives his talks, we'll have him concentrate on emergent reasons for spine surgery. Ventriculostomy, very common way to treat increased intracranial pressure. It's really no more complicated than putting in an arterial line, and it's easier than putting an arterial line in. Can be done at the bedside. And generally, if a patient needs a ventriculostomy, it might look barbaric if they're not intubated or anesthetized, but they're generally in a condition where they can't feel anything. They're comatose or near comatose. But certainly normalizing somebody's intracranial pressure by putting a ventriculostomy in can save somebody's life very quickly.
What is a ventriculostomy?
We put a little, what we were showing over there, we put a little hole in the head at a certain measure back from the nasion and measure at a certain point in the head. Make a small incision in the scalp. This drill that comes in the kit, you make a very small hole about the size of a pencil, and then aiming at two different landmarks on the scalp, on the skull, you just advance a tube about 5 centimeters into the ventricles of the brain, one of the ventricles of the brain, and the fluid comes out the tube. For people that aren't absorbing the spinal fluid well, or have something else, another mass in their head, and you can't evacuate that mass, but you can take something out of the brain, out of the head, to decrease the pressure temporarily, so you take spinal fluid out. We try to do them in the OR if we have to, but I would say probably half the time they're performed either in the emergency room or at the bedside, because waiting until it takes somebody to the operating room, they would die in the meantime. Obviously, so as we treat these emergencies with an open craniotomy, and we've kind of discussed open craniotomies before. General medical therapy, we want to, again, maintain cerebral perfusion pressure. And that's a balance between their mean arterial pressure and their ICP. Subtract the ICP from the mean arterial pressure, and the difference is the pressure that there is to perfuse the brain. Generally, you want to keep that over 40 millimeters of mercury. You don't want it to be below that. And you can treat that in many ways. If you treat it by decreasing intracranial pressure, you can influence perfusion pressure by increasing mean arterial pressure, or do a combination of the two. That can be done obviously with hypertensive medications, putting somebody's head flat, putting a ventriculostomy in to drain fluid so that to drain spinal fluid so that the pressure in the head goes down, giving agents to raise the blood pressure. We can do the next thing, which is to dehydrate the brain. So if we shrink the brain and change blood flow to the brain by using hyperosmolar fluids like mannitol, urea, hypertonic saline infused intravenously, then again we're decreasing the volume of the brain, either the blood volume or the brain volume itself, by basically, like a sponge. If you squeeze water out of a sponge, it shrinks in volume. If you can get some of the water out of the brain tissue temporarily with these mannitol or urea, hypertonic saline, by causing a diuresis, then the brain's going to shrink temporarily. And it's not going to last long term, it's not going to be a long-term effect, but it certainly can save somebody's life who's suddenly dilated a pupil and you want to get them down to the operating room. If you give them a slug of mannitol, you will decrease their intracranial pressure temporarily and buy some time to do something that's more effective. People with tumors get edema surrounding the tumor, more fluid in the brain, they get swelling. Put them on high and low dose steroids, which tends to reestablish the blood-brain barrier and cause less fluid to leak out from tissue surrounding the tumor or the infection. Hyperventilation, not a good long-term cure for or treatment for increased intracranial pressure because the body accommodates to it very quickly, but certainly temporarily we can hyperventilate somebody, reduce their PaCO2, which causes constriction of their blood vessels, which decreases blood flow to the brain. It's one of the components of the volume of tissue, volume of stuff in the skull. So we can decrease the blood flow to the brain, then we decrease the arterial flow and the venous volume. Therefore, our ICP can come down temporarily. Other emergencies we talked before. Stroke is an emergency. We treat that with the various interventions. Again, that's a separate talk that we'll come back and give. I'll come back and give it another time. In terms of the studies supporting or not supporting different treatments for stroke and when it's appropriate. Other emergencies, subarachnoid hemorrhage from ruptured aneurysms. Again, separate talk in terms of the details of it, but you know the emergency there is we don't want the aneurysm to re-bleed. You have a ruptured aneurysm, you have about a 20% chance in the first 2 weeks afterwards that it's going to bleed again. Every time it bleeds, there's a 60 to 70% chance of dying from it. And so we want to get that aneurysm repaired as quickly as possible. Not because it's going to make the person any healthier, but it's going to reduce the chance that the aneurysm is going to hemorrhage again. And simple things, sit the patient up. You know, their ICP's up, they're lying down, sit them up 45 degrees, increases venous drainage from the brain, and again, gets rid of one of the things that's in the skull, and that decreases intracranial pressure. So, obviously those are not in any specific order, but those are the multiple ways that we can treat some neurosurgical emergencies. And that's it. That's all I really had for the essentials of neurosurgical emergency treatment. If you want to use the other time to go into other specific things like stroke or things like that, I can certainly do that. I have those talks here.
Dr. Horwitz, how about if there was someone who needed emergency type procedures, if you could just share a little bit about reversal of high coag?
Oh, that's a good question. You do have a lot of patients that come in, the elderly who are on Coumadin or on Plavix, who have intracranial hemorrhages. If something needs to be done, it's done with them anticoagulated and try to correct them in the operating room. Certainly there are a lot of those patients who are not surgical candidates to begin with. They may be too devastated already, and you know the operating room is not going to make them any better, but if you think you can help them, we don't wait in the ER. We try to get them corrected in the ER while they're being transferred to the OR, but if we can't, they get sent to the OR and get corrected there. Obviously for Coumadin, they would get FFP. We might give them some platelets as well. For people with liver disease, cirrhosis, they're very hard to correct. Even if you get their numbers looking normal, they generally continue to bleed anyway because their factors just don't work properly. But we do try to correct them as well. Very often, if we can't get FFP from the if we can't get FFP from the lab quickly enough, they'll be given factor 7. I don't think there's factor 7 here now, but we've talked to them about stocking factor 7. It's very, very expensive, and we generally set up protocols for which patients receive factor 7. The beauty of factor 7 is it will immediately normalize your coags, even if you have an abnormal PTT. The downside is, as I said, it's very, very expensive, and it wears off and has to be redosed until they're corrected. But if somebody comes in and needs to be rushed to the OR, they'll be given factor 7. And factor 7 even has been shown to be effective in people with normal coags. If you give them factor 7, take them to the OR, they'll have less bleeding than somebody that was not given factor 7. But to use it routinely, while it may have less bleeding, it may not affect outcomes in those patients. So it's really too expensive to just give it to everybody. But as I said, there's really not a it's not the kind of thing that precludes somebody from going to the OR. We try to take them to the OR with normal coags if possible.
So so we talked a lot about the emergencies that would take them to the OR. How about emergencies post-op? Any more specific to complications of craniotomies that we might see, or complications that we have to address that we haven't talked about yet?
No, I think we address all of them. The main emergency following craniotomy is, I mean, bad things can happen, but they're not necessarily emergencies that need to go back to the OR. So the biggest emergency, obviously, needs to go back to the OR after surgery is either brain swelling or hematoma or new blood clot. Not all those patients have to go back to the OR. Some do, some don't, depends on what it looks like. Obviously, treating neurosurgical emergencies doesn't just involve going back to the OR. A lot of those patients, might need to be reintubated to maintain their airway if their sensorium is off. They may need the agents that I talked about, the steroids, the mannitol, the urea, the hypertonic saline to get the swelling to come down. They may go back to the OR, just have the bone flap removed so that the brain can swell out instead of in and destroy normal tissue. But again, it's basically the common denominator is if they're having a problem and it's because there's mass in the head, you want to make sure cerebral perfusion pressure stays as normal as possible. Whatever you can do, whether it's surgical or non-surgical, all these interventions are aimed at improving and normalizing cerebral perfusion pressure. Patients, relatively non-surgical emergencies, but are still problems that we need to look out for are patients that have microvascular decompressions and that have let's say I told you about pain in the throat or pain in the ear, that have surgery on their 9th and 10th nerves, the nerves for swallowing. Those patients can have dysphagia afterwards, just like cervical patients can have. So they may be at risk of aspiration, and that has to be evaluated with swallowing tests. If you're worried, if we're worried about it at all, it's a concern that kept NPO. And that's not a neurosurgical emergency, but it's certainly something that can cause an emergency very quickly if you decide to feed somebody that can't control their secretions or their food and liquid.
And then I know it's not an emergency, but a complication, particularly if they have a drain, is meningitis. So can you go through us how the nuchal rigidity and the different signs of meningitis that
Sure.
we would see?
Sure. Well, I mean, meningitis can occur either post-surgical or post any type of manipulation that introduces something into the CSF space. So it's not common post-surgical in terms of bacterial meningitis. Infection rates overall are generally somewhere around 3% or less, and that includes skin infections, spinal fluid infections, CNS infections, and it's somewhat lower with lumbar drains and external ventricular drains. In terms of a CNS infection, you might get soft tissue infections. But in a patient who has had recent surgery, we talked before about etiologies for a change in neurologic exam, or who's had some type of drain put into their CSF space, fevers and any change in their sensorium, decline, hyponatremia is a sign of infection. Those things need to be just aggressively worked up, and infection needs to be on your list. Generally, patients that have a drain in, either a lumbar drain or an external ventricular drain, will get fluid sent each day to be evaluated. Not always held for culture, but at least sent for chemistries to make sure the glucose and the protein and the white cells are normal, within normal range. The thing you have to remember is everybody that's had a craniotomy that has fluid sent afterwards they're going to look like they have a meningitis. They're going to protein, you've manipulated their brain, you've spilled bone dust and blood into their spinal fluid pathways. Their protein's going to be high. They may have elevated white cells because the white cells are responding to the irritation from these foreign substances. They normally won't have the best thing to look at is their glucose. They should not have a low glucose. Glucose is generally low when there's bacteria that are using the glucose up. So as long as that glucose is greater than 40 or 50, we don't worry too much. Some people will still complain of symptoms that are very similar to bacterial meningitis, but it's chemical meningitis, and again, it's from the irritation of the bone dust, from the drilling, blood, anything that got into the CSF pathways causes irritation of the meninges and give them symptoms very similar to meningitis, but it's non-infectious. It's generally self-limiting. Once we've ruled out that it's not from an infection, they generally respond very well to either steroids or Toradol.
With those drains, how much drainage would you expect? Or is there a certain amount that you would want called for? Is that if it drains a certain amount over a period of time?
Well, for the ventricular drains, usually they're in, and we're monitoring ICP. And as long as the ICP is, we'll say put it at 15 centimeters above mid-drainage, the tragus, which is about normal ICP. You'll call us if, we'd expect to be called if the ICP went over 20 or 25 for more than 10 minutes. Whenever a patient moves around or coughs or something, it's going to go up, but then it doesn't come back down to normal. So we might say, call a house officer or call Dr. X for ICP greater than 25 for greater than 15 minutes. And then we'd say drain some fluid or drain some more fluid. But normally it's just left open at 15, and whatever drains, drains. If it's open at 15, their ICP, unless there's something going on, should not exceed what it's open at. Because if it's open at that, at 15, it's going to pop off and drain fluid. Now, it might get clogged. You may have drained all the fluids, now there's nothing left to drain, and now it's going to show increased pressure, but there's no more fluid to come out. So we usually don't ask for a volume. Now, we may follow the volumes and see how much. If somebody's draining a lot of fluid, then you know that their pressures are fine, but you know that, wow, they're draining 200 cc's of fluid a shift. They're obviously not reabsorbing it properly. This is not somebody that you're going to be able to take the ventriculostomy out if they still need it. Usually towards the end, when we're trying to wean a ventriculostomy, let's say for some reason we had it at 15, and we're thinking of taking it out. We'll say, raise it to 20. Raise it to 20, which means you're going to drain less, and then we'll go around and say, how much drained at 20? Well, the same amount drained at 20. Well, that's problematic. If you tell me less drained at 20 and they're doing well, I know that it's being reabsorbed elsewhere. The fluids, the pressure is never exceeding 20 that often. Because when it's open, you can't really monitor pressure. And then eventually, usually before we take it out, we'll clamp it and just close it off and monitor the ICP for either overnight or for several hours and see what's going on. If it's normal, then we'll pull it out. We try not to ever take a ventriculostomy out unless we have to at night, so that we want people around or available if there's a problem and it needs to be reinserted. In terms of lumbar drains, it's different. We rarely use lumbar drains for cranial problems, even though in most of the cases it's safe to. We very often don't use it for that reason. If we are, then we would specify, because it's not this, the people are laying flat, or if they're sitting up, the pressure may not be read accurately. So in those cases, we usually specify them out. And it depends on what we're doing, but normally it's somewhere between 60 and 90 cc's a shift. Your shifts are Q8 hours, so 60 to 90 cc's every 8 hours. We try to titrate it, have you titrate it, so if that's over 8 hours, they drain that. It's not 80 cc's in 15 minutes. If that were to happen, it's not the end of the world. We prefer it not happen because it can cause problems. It can cause shifts in the brain and bleeding. But if it happens, if you get your 60 cc's over 4 hours, then because the patient moved around or things changed, we say, you just clamp it, and when the next shift comes around, you open it up again, and maybe raise it a little bit. Generally, people with lumbar drains, they're asked if they're cognizant enough to call when they want to be moved. So if they go to a chair, it's adjusted versus lying down in bed, or if they walk around, we'll clamp it. Other thing about the ventriculostomies and the lumbar drains, if they become disconnected, that could be a source of infection. We never flush, unless for some specific reason, we never flush into a drain, because we can introduce bacteria down the drain into the CSF space and cause an infection. So we generally only want to let fluid draw come out of the drain. Very rarely we will inject it in a drain that we don't think that we're worried it's clogged. We want to inject sterile saline. We would never ask one of the nurses to do that. We would do that ourselves. If it becomes disconnected and there's nobody around to do anything, we just tell somebody to put a clamp on it, put an hemostat on it, so it doesn't keep leaking fluid and there's no route for bacteria to go the other way. Put some betadine on the end and tape it up, and somebody will come and take it out at some point. But those are not emergencies. They just increase the risk of infection if possible.
Are you going to be doing LP or DP shunts?
We rarely do LP shunts. Usually, almost always it's DP. The LP shunts they have a very high failure rate long term.
We haven't done them in a long time. That's just one.
Yeah, no, we very rarely do them. The only time we'll do them, and usually LP shunts are only done for women with pseudotumor. And it'll be done if their ventricles are so small that you don't think you can put a catheter in the ventricle. Now with neuronavigation, if the ventricles are really small and you're worried you won't be able to do it freehand, you can put it in with the neuronavigation because you can see where you're putting the catheter. We do lumbar drains though a fair amount for our patients with normal pressure hydrocephalus to evaluate them preoperatively. And those are older patients. They get a lumbar drain put in. We would do them on the floor. At Presby here, we would do them in the unit. They get a lumbar drain put in. They get 60 cc's drained on average per shift, maybe more if they're not responding. And they get physical therapy comes by and evaluates them once or twice every day, evaluates their gait, some of their strength, but usually called the dynamic gait index, how long it takes them to walk a certain distance and take a certain number of steps. And if they improve over that period of time, the family thinks they improved also, then we offer them, after 3 or 4 days, we offer them a programmable shunt. If they don't improve, or sometimes they get worse, then we just take it out and send them home. But that way we don't put shunts in everybody that looks like they may have NPH. Okay.
I'm just reminding you had forgot to talk about during the craniotomy lecture, lumbar drain, subdural drain.
Yeah, that's right, thanks. I said before, after craniotomies, that we sometimes leave drains in the brain cavity if we took out a clot, or in the certainly most frequently in the subgaleal space between the scalp and the bone, just to take blood out from that potential, well, it was a potential space, now it's a real space because we created it. We don't want a big blood clot there that can become infected. But sometimes, not sometimes, most of the time, if we're doing a subdural hematoma, we'll leave a drain in the subdural space, and those drains generally get left in for a couple of days. They're usually placed to grab, so they're now in the subdural space beneath the dura, brought out through a separate stab incision of the scalp. They're not placed to a grenade under suction. They're just placed to gravity drainage in a bag that's just left by the bedside. Hopefully, as the brain re-expands, it pushes that blood out, and then those patients are followed by both seeing how much blood's coming out and by their CT scan in a day or two when everything looks like there's either nothing draining out or it's just spinal fluid that's draining out. If you got into a CSF space or the CT scan was good, we'll just pull that and close the stitches already in there and close that up. I mean, it kind of brings you to a little bit of a potential neurosurgical emergency. If for some reason there is a drain in the head or it's against the dura, let's say we took out, let's say we did an operation and we left the bone out and we closed the dura up and we put a drain in as to suction. There are occasional instances when you apply suction to the dura, somebody can become bradycardic. So if you notice that you put the bulb on and somebody suddenly became bradycardic, we would the first thing you should do before you but the first thing you should do is let go of that suction. Not for subgaleal drains, but for anything that's against the dura, because then you want to get rid of the suction on the dura. It's just the dura has pain sensation, and obviously pain sensation can cause bradycardia. So sucking on the dura may not cause the person to feel pain, but it stimulates those nerves and can cause bradycardia in response to it. It's really weird, you know,
You
this
generally,
talk was longer. I don't know what happened to it.
What about, I don't know, outside of high-grade subarachnoids, which I know we won't keep the high-grade subarachnoids, but cerebral salt wasting, do we need to be worried about that in any of the other cases?
We do, but honestly, that just goes under the broad category of hyponatremia. The only thing, I mean, we could certainly do like a separate hour on management of hyponatremia, and I have a talk on that, and I'm fine for that. And it probably is a useful talk, especially for the ICUs. But between, you know, people used to think that most cases of hyponatremia was due to SIADH, which is inappropriate antidiuretic hormone release. The reality is it's probably, I don't know if I can say that. But anyway, in reality, probably more cases are due to cerebral salt wasting. You can't really, just at the bedside and with regular lab testing, you can't really distinguish the difference. One is a patient that's actually fluid overloaded, and one is a patient that's fluid underloaded. But you can't really detect that without measuring plasma volume, which is a radioactive study. So, but the bottom line is, in almost all those patients anyway, if they get hyponatremic, if you fluid restrict them and give them salt replacement, they will normalize. Even though the mechanisms are totally opposite, they will normalize. So while it's a good academic discussion and physiologic discussion, the bottom line is if somebody's sodium starts to drop, give them sodium. And you can fluid restrict them as well, but the goal is do whatever you can to keep their sodium above 130.